Thank you, Professor Mahmoud, for the introduction. Good afternoon, everybody. I'm going to talk about the aberrations. I'm going to talk about the aberration in the form of a case study. Are the aberrations really a big deal? I don't have any financial interest in this presentation. This is a case of a male patient, 28 years old, asking for refractive surgery with normal general health and no history of contact lens wear, with a stable refraction for 5 years, and the best corrected visual acuity was 20/16 OU, with this refraction minus 4.75, minus 1.5 in the right eye, minus 3.75, minus 1.5 in the left eye, with mesopic pupil 5.2 and 5.1 millimeter, and cycloplegic not that different from the manifest refraction, but the brachymetry was slightly thin, 502 and 504 microns OD and OS. This is the pentacam of the patient. Everything is normal, regular bow tie, normal anterior and posterior elevations, and the thickness map showing that the corneal thickness is 502. And this is the same for the left eye with the corneal thickness 504. So the decision was to do SMILE procedure, and it went uneventful with the use of the old VisuMax 500 with optical zone 6 millimeter and transition zone 0.1 millimeter. The optical zone was slightly smaller because of the corneal thickness, so I keep the residual stromal thickness about 290. After 1 month, the patient came with blurred vision and glare more prominent in the right eye than in the left eye, with which is increase in the dim light. The symptoms were related to dry eye, as Dr. Tamer Gamali taught us that we are going to treat the patients with various types of artificial tears, and we used with him IPL, intensive pulsed light, for improvement of the meibomian gland function, but no improvement. We use brimonidine for pupillary dilatation during night to prevent that dilatation during night, but not successful in alleviating the symptoms. After 3 months, the patient is still complaining, and the uncorrected visual acuity is 20/20 OU and corrected to 20/16 with very, very minimal refraction. It's minus 0.25 and minus 0.5 astigmatism in the left eye, with clear corneas without epithelial staining, and the corneal thickness was 421 and 436 microns. The tear film analyzer showing good results or average results with tear breakup time 10 seconds in both eyes, and Shermer test was 12 and 13. That means that the patient has not that dry eye. He is good. This is the pentacam of the patient showing the lenticule extracting, doing some flattening of the cornea. It's not that centered, it's slowly decentered. And the left eye showing the centration was much better, although it's not that perfect. Here is the aberration, pre and post-operative in the right eye, pre and post-operative in the left eye. So the question, what is the cause of the low quality of vision, especially in the right eye? Dryness, and this was excluded. Low order aberration, and also excluded because the spherical and cylindrical errors are very low. Higher order aberrations, coma, because of the centered optical zone, or higher order aberrations, spherical aberration due small optical zone. When we go back to the aberration maps, we can see here that the third order aberration, the trefoil and the vertical coma, is much more in the right eye than in the left eye. Also, the spherical aberration is bigger in the right and than the left, although of the large effective optical zone of SMILE, but here we use a small optical zone of 6 millimeter. This is consistent with lower decentration, more in the right eye, and the cause of induced coma is decentration of the effective optical zone. So, we go back to the literature comparing the femto LASIK with the SMILE. The conclusion was, however higher vertical coma was shown in SMILE than when front-guided femto LASIK, which might be a potentially impact factor for patients' vision under certain lighting condition and needs further investigations. This means that the centration is an issue in SMILE. So what to do in this patient? Nothing, just reassurance and follow-up. To do ReSmile, to do femtosecond LASIK wavefront or topography guided with a circle technique for flap elevation, or to do PRK wavefront or topography guided. This was a very important question for me, but I decided to reassure the patient and to wait. After 3 months or 3 months later, the visual acuity is still 20/20 with marked improvement of the symptoms. What is the cause of this marked improvement of these symptoms? Back to the literature, comparing talking about the epithelial remodeling induced after SMILE, the conclusion in this paper was an asymmetric lenticule-like pattern of epithelial remodeling occurred in 9 millimeter diameter cornea at 6 months after myopic SMILE. This epithelial remodeling may affect the refractive outcome of SMILE. So, this patient improved because of the epithelial remodeling that changes the irregularity of the surface we made during the surgery. Now we have other machines, the new designs or the new versions of the VGMAX with good centration or better centration than the old one and with good cyclotorsion alignment than old ones. Again, to remind you, now SMILE is one of the procedures called CLEX or keratorefractive lenticule extraction. SMILE now is one of them. We have Silk, we have Clear, we have Smart Sight. Now we have 4 machines performing the lenticule extraction, and SMILE is just one of them. So, to conclude, SMILE is an effective refractive procedure, we all know, with minimal disturbance of the corneal innervation. Just 1 minute. 1 minute, please. It does not have the ability to center the ablation with precision that's available with LASIK. This may lead to small decentration of ablation zone like in our patient with induction of higher order ablation, especially the vertical coma. Please don't rush into enhancement because epithelial remodeling can do this job, can change the irregularity or improve the irregularity. New machines can improve the outcome regarding the centration and axis alignment. And thank you very much for your attention.
Thank you, Dr. Tamer.